to the CVP board members for arranging such conference. You made us really proud, guys, for this arrangement. And also, I would like to thank the CVP program directors for choosing me to present in this very special day. And today, I'm not only a proud cardiovascular technologist, I'm also a proud daughter, as my parents just came here to support me today. So thank you. So now, moving to my presentation, which is right heart cath and heart transplant evaluation. So from the presentation, I would divide my talks into two parts. First, I would go through the right heart cath procedure, what it is, what its indication, how we perform it. Then we're gonna go through the role of right heart cath and transplantation and into myocardial biopsy. So let's start. So what is right heart catheterization? It's simply an invasive test that shows how your heart is functioning and pumping. It measures blood pressure and saturation in the lungs and the right side of the heart. It's also called pulmonary artery catheterization. So who needs this invasive test? Or in another word, what are the indications of right heart cath? So it's indicated for patients with congenital heart disease to assess their heart condition and pressure, patients with heart failure to assess their volume and to optimize their medication, patient who has heart valve disease, pulmonary hypertension, and patient who will go for heart transplant before and after, and we're gonna discuss this in details later. So what is the procedure itself? What are we doing in cath lab in right heart cath case? First, regarding the access, based on anatomy, to reach the right side heart of chambers, we need to access a vein. So it's either a femoral vein, internal jugular vein, brachial vein, or less commonly subclavian vein. After getting the access, a small flexible catheter with a balloon-tipped flotation is introduced via the vein, and the purpose of this balloon is to help the catheter to flow with the blood flow inside the chambers, from RA to RV, PA, then finally pulmonary wedge pressure. And these steps are monitored either by fluoroscopy guidance or by the waveform in the hemodynamic screen. So let's see each chamber, how we can see it under fluoroscopy and its waveform. Starting from RA, as you can see in the fluoro, this is a catheter, a Swan-Ganz catheter introduced in the RA. And in the left side is the waveform of RA. The normal RA pressure is approximately 5 and mean of 3. Moving forward to RV, we're gonna introduce or advance the catheter into the RV. This waveform will appear in the hemodynamic screen, and the normal value of RV pressure is at approximately 25/4. Then we're gonna go to PA pressure, and we're gonna see this waveform, and the normal PA pressure is around 25/9, mean of 15. Then lastly, we're gonna go to wedge pressure, and the trick here to obtain an accurate wedge pressure is to advance the wedge or the Swan-Ganz catheter to the distal end of PA. Then we're gonna inflate the balloon to occlude whatever is behind the catheter and to make the catheter sensing whatever is in front of it, which is indicating and reflecting the LA pressure. And the normal wedge pressure equal 4/12 approximately and mean of 9. So let's just review the normal values. RA is 0 to 5, RV is 15 to 25, MPA is less than or equal 20 millimeter mercury, wedge pressure less than or equal 12, cardiac output more than 5, pulmonary vascular resistance less than or equal 240 dynes per second per centimeter. So now there are some terms that we must know if we are performing right heart cath. Simply the heart rate, which is beats per minute, then stroke volume, which is the volume that the heart is pumping per beat. And in order to get the volume that the heart is pumping per minute instead of per beat, we're gonna multiply the heart rate with the stroke volume to give us the cardiac output, which equal the total volume pumped per minute. Then we have index, which is proportional to the body surface area to the patient. So now if we are going to measure the cardiac output in cath lab, we have two methods, one called FIC and the other called thermodilution method. What are the differences and what are the concepts of these two? Starting from the FIC, it relies on the recognition that the total uptake of oxygen by the peripheral tissue is equal to the product of the blood flow to the peripheral tissues and the arterial venous oxygen concentration difference. Therefore, the formula of cardiac output by FIC equal the estimated oxygen consumption divided by the arterial venous oxygen difference. On the other hand, the thermodilution method, in order to perform it, you need to inject a fixed volume of cold saline as a bolus into the RA through a proximal port of Swan-Ganz catheter. As the flow, or as this injected saline goes from RA and passes to RV until it reaches BA, once it reaches BA, we need to measure the temperature of blood there, and the degree of the change in the temperature in the PA is proportional to cardiac output. What does that mean? It means if the temperature changed rapidly, it means patient has a high cardiac output, and if the temperature changed slowly, it means this is a low cardiac output. What are the supplies needed for these two procedures? Both of them, we need, of course, introducer sheath and access wire, but for FIC, we need any type of catheter. In the thermodilution, we have to have Swan-Ganz catheter. And why is that? Because the thermodilution has a thermistor located at the tip of the catheter to enable the catheter to measure the temperature. For FIC method, we need a heparinized syringe to calculate the PA sat, as the FIC depend on the oxygen consumption. On the other hand, the thermo, we don't need the PA sat, but we need a cold or room temperature normal saline to inject it into the heart chambers. So if you decide to go with the thermodilution method, there is some consideration you need to take in mind, which is you cannot do it for patient who's having tricuspid regurg or patient who has intracardiac shunts. And why is that? If patient has intracardiac shunts, it will overestimate cardiac output. On the other hand, patient has tricuspid regurg, it will underestimate the cardiac output. So these tips and reminders for right heart cath procedure: always make sure to establish the zero level and balance the transducer, and always try to record pressure at end expiration. Why is that? Because during inspiration, the pressure will be lower due to decrease in the intrathoracic pressure. So after understanding the right heart procedure, we will go now to understand the role of right heart cath in heart transplant patient. We're going to start with the pre, then we're going to post-transplantation. So starting from pre-transplantation rule of right heart cath, so I tried to summarize it in 3 simple points, which are assessment of pulmonary hypertension, optimization of therapy, evaluation of hemodynamic status. Why do we need to assess pulmonary hypertension for a patient going to heart transplantation? Because we need to know, is the pulmonary hypertension is fixed or reversible? If it's fixed, which is irreversible, it means the patient has a high risk of rejection after transplantation. And interestingly, if the PVR, if we calculate the PVR for a patient going for transplantation and we found it more than 4 Woods in it, this considered as a contraindication for a patient to go to transplantation. Why is that? Because even if we implant a new heart to that patient, the new heart also will fail because the heart will not be able to inject the blood against the very high pressure of PA. So RV will be failed, heart will be failed, the heart failure will come again, and the circle will come again. So if we find that patient has a high PVR, now we're gonna go to the second point, which is optimization of the therapy. We will gonna optimize the therapy, or we're gonna maybe think about a bridge device, which is VAD, RVAD or LVAD, which is ventricular assist device. If it's improved, we can go and send patient to transplantation. Lastly, the evaluation of hemodynamic status. Simply, we need to do that to identify or to confirm the severity of heart failure and to confirm that the patient is really indicated for heart transplantation. So after knowing that the patient is really indicated for heart transplantation and we send him to transplant, he will go back to us after transplantation. And what is the role of post-transplant rule for right heart cath? It's simply to monitor the allograft rejection and to assess long-term follow-up. I'll try to summarize it here because I have only 1 minute. So for monitoring allograft rejections, we need to evaluate hemodynamics. We need to check the RA pressure, wedge pressure. If it's elevated or if the cardiac output is severely reduced, this is a sign of rejection. And also we are doing some diagnostic procedure called myocardial biopsy, which is a diagnostic procedure that involves taking a small amount of tissue from the RV and heart muscle to evaluate heart tissue after heart transplant to make sure the body is not rejecting the transplanted heart. What are the supplies that we need for biopsy? We need simply long sheath and biopsy forceps. And why do we need long sheath? We use it as a delivery system because the biopsy is considered as a shark, so we cannot introduce it into the vessel simply. We need to introduce the sheath until the RV to make a safe way to the biopsy to be introduced.
Good.
Can I have 1 second? So we need to make sure that the biotome always longer than the sheath, so we can advance the sheath, advance the biotome to take the biopsy sample. These are the angiography for biopsy. As I told you, there's the sheath introduced first, then we advance the biopsy, then we can advance the bioptome, and we took the biopsy sample. So to summarize it, pre-transplant rule of right heart to assess pulmonary hypertension, evaluate hemodynamic and optimize therapy, post-transplant to monitor rejection and to assess long-term follow-up. These are my references, and in conclusion, I can say that right heart cath is a gold standard tool in heart transplant evaluation because it's ensuring optimal patient selection, accurate diagnosis, as well as effective post-transplant management. Thank you so much.